I didn't change the name because elastography and DFI, it's the baby of Marc. And Julio is right if he's waiting for Marc Giovanninni. And I stole entirely the presentation of Marc. I didn't change anything. Because in the unit, we cannot touch elastography. So we have some progress with US. You see it previously in the different slide. And now we have a new machine from Hitachi, a very good machine who allows probably better characterization of the tissue. And why better tissue characterization is because sometimes biopsy is inconclusive. Sometimes biopsy is risky, as IPMN with a risk of acute pancreatitis, pancreatic juice leakage, or risk of bleeding. And so we have now two tools with this new machine, shear wave elastography and the detective flow imaging DFI. The elastography, described previously, is machine making compression with variation and distortion, and with this distortion we obtain with a soft, of course, a colorization of the it doesn't work anymore. A colorization of this distortion from soft to hard, from red to blue. That is an example. You saw it previously again. In green, it's a soft tissue. It's a normal pancreas. You have a chronic pancreatitis below, and the tissue is heterogeneity with a lot of blue because it's harder than normal pancreas. First, we have a colorization. Marc Giovanninni described categorization of the colorization from green to blue with five stage. And with this colorization, a number of authors, including Julio Iglesias, the second father of elastography, allows to diagnose pancreatic cancer or another mass. But the color is sometimes difficult to diagnose, to do a decision with just a color with elastography. So strength ratio has been created, and as you see, the pointer doesn't work, but as you see, you have to compare the lesion and the tissue around, and with this comparison, you have a number, so it's easier to conclude if the lesion is hard or not. You have not color. And with this strength ratio, the author can distinguish pancreatic cancer, normal cancer, chronic pancreatitis. But as you see, the ratio is different depending on the author. It's depending on the author because you choose your standard yourself. If you choose your standard here with the wall bowel or here with the pancreas, you won't have the same strength ratio, and it's a problem because in papers you never have the same strength ratio to distinguish pancreatic cancer and chronic pancreatitis. So first, quantitative elastography strength histogram has been created. It's very complicated. To use it, you focus your lesion, and as you see, you focus the strength histogram, that is graphical representation of the color distribution representing the tissue elasticity in a selected region of interest. And you have 4 parameters. The mean, it's the arithmetic mean of the histogram with a higher value indicating soft tissue. a standard deviation, a measure of the spread of values on the histogram with a higher value indicating heterogeneous hardness. Skewness, a measure of the asymmetry of the histogram with a higher value indicating hard tissue. And you have the kurtosis. It's a measure of the thickness of the histogram with a higher value indicating a concentration of specific hardness. As you see, it's not simple. In practice, you focus the area of interest and you obtain your histogram and with your measure. And to distinguish the different mass, you have to apply this simple formula. I won't read it because it's very complicated, but to read it, it's difficult. But of course, you cannot use it for each US contrast you do, because the time you read the formula, the procedure is finished. So Hitachi refused to include this formula in the machine. So strain ratio was bound, and now we have the shear wave elastography. It's a new elastography. Probably we will use only shear wave elastography. Julio Iglesias will have to do new studies. And the shear wave is based on the properties of the shear wave and involve a Doppler-like ultrasound technique to monitor shear wave propagation and measure the velocity of the shear wave. It means it's just ultrasound. You push the button and the machine calculates the softness or the hardness of the tissue. You see, you have in kilopascal here, 11, 5, 11, a measure of your tissue. It's easy, and you have no a standard. You needn't a comparison with the around tissue. We have two studies in the literature. A study by Ono with the feasibility and usefulness of endoscopic ultrasonography, so guided shear wave measurement for assessment of autoimmune pancreatitis. And they found a difference between autoimmune pancreatitis and normal pancreas. And probably these results are reproducible. That is important because it's thanks to the shear wave. And the study of Yamashita, where endoscopic ultrasonography shear wave is used as a predictive factor of endocrine, exocrine dysfunction in chronic pancreatitis. They included 40 patients, and they find good sensitivity, good specificity to predict the problem of the pancreas of the patient. The important thing, it has been described also by a previous author, but the important thing is we believe this shear wave will be reproducible. The contrast, it's the same presentation of Julio. So as you understood, adenocarcinoma on your left is not enhanced, and endocrine tumor on your right is enhanced with project contrast, and it allows to do the difference between this kind of tumor. Graphically, it's well explained. In red, you have adenocarcinoma. You see a bit at the top, no enhancement, and endocrine tumor, high enhancement, very quick of the endocrine tumor. The finding of hypo-enhancement lesion was a sensitive and accurate predictor. Oh là, qu'est-ce qui se passe? Oh. I didn't touch anything. It doesn't work. So hypo enhancement has a very good predictive positive value for adenocarcinoma. I don't remember this exact slide. It's from Julio has presented it before. It's 93%, 96% in meta-analysis. So it's very useful to do contrast when you have a mass and a negative biopsy. If you have a hypo enhancement, repeat your biopsy. Yeah, I touch. Okay, it's done. That's the same thing I said. The very high sensitivity for contrast with hypo enhancement, and to distinguish adenocarcinoma from another tumor. What is interesting is the mural nodule in IPMN. In IPMN, when you follow a patient, you have potentially a mural nodule on MRI, on EUS. And sometimes it's difficult to distinguish mucus from a true malignant nodule, because the true nodule involve surgery, probably. So we can perform sonoview. You see that is a nodule here, l'attaque. You see it, it's moving. And on your right, you will have the contrast arriving maybe in the nodule. So it's very small, the patient is breathing, but you see the nodule is enhanced. You see it? To help you, we measure it. And so this little nodule, less than 5 millimeters, is a sign of malignant lesion. And if you can biopsy it to have a pathology, but it's not so easy, because in this example it's possible, but if your nodule, of course, is here, it doesn't work anymore. Here, of course, it will be difficult to biopsy with the MRI biopsy. In this series from Japan, 17 patients, and they found a pathologic, on the pathologic findings, 12 nodules on 5 clots. The contrast depicted vascularity in all 12 cases, and no vascularity in 4 patients among 5 for mucous clots. The accuracy was 94. So its contrast for IPMN nodule is very, very important. That is the image of the one patient, and you see there is enhancement of a nodule. You see it? Well, contrast for nodule is very important. In this review by Andrea Lisotti from Italia, 10 studies, and the primary outcome was poor sensitivity for identification of high-grade dysplasia or invasive carcinoma, and the poor sensitivity of contrast was 88%, the specificity 79%, so an accuracy of 89% in this meta-analysis. That is also the same thing, comparing contrast to scanner, and the contrast with US is better. We knew it already, but we need a study to be sure. The contrast is better than the other technology, but the other imagings. Contrast can be used, I think. No. Can I go back? No? Okay. We can use also the contrast to be sure we will perform RFI on endocrine tumor, and to be sure we destroy the tumor. You see a lack of enhancement after RFA to be sure the treatment was efficient. Contrast can be used also in submucosal lesion, in GIST. In GIST, you have hypervascularization, and you can distinguish GIST from leiomia, from lipoma in difficult cases, and you can distinguish GIST with low-grade malignancy from high-grade malignancy because the GIST have hyper-enhancement. The GIST, the contrast is better, of course, than US. And here you will see the images with vessels inside. I think it doesn't. Well, and you see the sonoview for a GIST. This GIST is very hypoechoic. We don't know really what it is. It's for the GIST or leiomyoma. But you see these vessels characterize the GIST. And you have a necrotic area just in front of the vessel. Is a high-grade malignancy of GIST. And now, beyond the contrast, we have DFI. DFI, detective flow imaging for endoscopic ultrasonography, is a new imaging modality developed for detecting fine vessels without using ultrasound contrast agents. We have two studies with submucosal lesion, pancreatic mass, and vessels were imaged in 44 pancreatic solid lesions. Here, up. Okay, something doesn't work. 8 intraductal papillary mucinous neoplasm and 5 gallbladder lesions, and 4 swollen lymph nodes. And you see, when you have a correspondence between vessels positive on DFI and vessels negative on DFI, and positive and negative on contrast. You have some vessels not visible on DFI. It's probably maybe less sensitive, but the correspondence is very good. And what is DFI? That is an image of DFI. And you see the pancreatic adenocarcinoma with vascularization around and no vascularization in the adenocarcinoma. Oops. And the same for contrast enhancement. In video, here you have vessels in the lesion. Probably it's not the same image than contrast enhancement. We have to be trained with a DFI to be sure we can recognize vascularization with DFI, because it's easier probably with contrast, as you see on the picture. But studies are ongoing, and it's very promising because we see very well the vessels with DFI, and you don't need contrast injection. So the new ARETA US scanner provides us a new insight in diagnostic US tools, use of shear wave elastography, the contrast and DFI, contrast without contrast product, to give us a better tissue characterization. And besides, the contrast US today is mandatory for IPMN workup.